Okay, so one topic that has been requested by a couple of you guys is a talk on how to work up anemia. Anemia is a very difficult topic. You could spend hours reading about how to work up different things. So hopefully by the end of today's talk, you guys will have a basic framework for how to think about anemia and what tests you need to order in certain situations. And so my hope is that we can go through some mini cases that I prepped for you all today. And then if you guys have actual patients with anemia that you've worked up, we can use this framework to see if we can come up with a diagnosis for them. Any questions on that? All right, so before we start, we have to define anemia. What are some numbers that you all have heard of? To define anemia. MCB. Okay, you can use an MCB. What else can we use? Hemoglobin, great. And what a value less than what is considered anemic? Yeah, so less than 12 for females, less than 13 for males. Those numbers are not meant to be like gold standards. They were done on a bunch of patients who had various like nutritional deficiencies and things like that. So use it as your ballpark, but a patient can still be anemic if their numbers vary from that. And so just have it laid out for you there. I think I'm pretty unique in that most times when you go to look up anemia and how to work it up, lots of times there are schema that are based on lab values. How many of you use that to guide your anemia workup? Most of you. Seeing some heads nodding. So I actually think about anemia in terms of timing. And I do that because I think that there are different things you have to worry about based on how acute the anemia is. And so let's walk through some initial cases. So our first patient is going to be a 56-year-old male who is admitted to the ICU for necrotizing pancreatitis. Yesterday, his CBC was as on the left. He had a hemoglobin of 13. This morning, you come in and you get sign out saying his hemoglobin is now 5. His heart rate is 120. His blood pressure is low. This was all new. They had to start pressors on him overnight. And when you're examining him, you see some left flank ecchymoses. So take about 1 minute with your tables and talk about what tests you want to order to work up this anemia and why you think he has it. And then we'll come back and chat as a group. All right, so that minute is up. Let's start here with Catherine and Kyle and Mike's table. So what are some things that you guys would do to work up this anemia, and what are you worried about for this particular patient?
Worried about GI bleeding.
Okay, worrying about GI bleeding. So he's anemic because he's losing blood somewhere. Yes, so blood loss is the cause of this person's anemia. Table 2, anything different? Biggest concern. Okay, table 3, anything differently that you would do? Nope, we just had a diagnosis. So okay, so you would scan and give blood. Perfect. So, oh, go ahead, Claire. Did you have something else to add? Okay, so this patient has had an acute change in his clinical status. He's tachycardic, he's in shock, and his hemoglobin has dropped. So the appropriate working differential is hemorrhagic shock for this patient. That left flank ecchymoses, what does that make you think of? Yeah, so a retroperitoneal bleed. So people can bleed from all different places. So GI bleeding is the #1 thing to rule out. If there's no melena, if there's no bright red blood, they're not having any hematemesis or like pink frothy sputum in their endotracheal tube, if they have that, you can sort of cross that off. But when you do your physical exam, if they have bulging flanks, you worry about an RP bleed. People can also hold a lot of blood in their thighs, in addition to their abdomen and their chest. So that's where you're thinking that this blood's gone. Great. So, for here, our workup is really about management. So we're going to get a CT scan, and then we're going to give blood. So that's the most important thing for this patient. Questions on this case?
Do you need to confirm that they're looking on the CT before you blood?
Great question. So do you need to give, do you need to wait to confirm that there's bleeding before you give blood? I'm seeing some people shaking their head no. Anybody want to take a stab at answering that?
Just give blood. I think with that kind of a drop and with, with someone that's like doing urgent management or
Yeah, so
like if he needs experts and you can't get stuff back, I'm not sure, but like ideally building back up is the best.
So. Great answer by Dr. Brixton. So this patient is in hemorrhagic shock. You're not going to wait to confirm it. You have a CBC that's back. Their vitals have changed. You're going to give the blood and then send them down for the scan once they're stable. Okay, let's move on to our next case. So we have a 27-year-old female. She admitted after some labs drawn at her PCP office after a spontaneous abortion, demonstrated the following. So she has a hemoglobin of 4.5, platelets of 70, creatinine of 1.5. For her physical exam, her vital signs are all normal. For her neuro exam, she has some weakness in her right arm, some mild dysarthria, some scleral icterus, and conjunctival pallor. So again, talk with your teams. I'll give you about 1.5 minutes for this case, but tell me what lab tests you want to order. And then if you have anything that you'd want to do urgently for her, for management, we can also talk about that too. So about 1 minute, 1.5 minutes per table. All right, so we will come back together. So let's start off with this middle table here. What tests do you guys want to order to help work up this patient's anemia? (1098). So you would go to that if you're good team. Yep. K3. All right, so while our great team is running off to go to that code blue, middle table here, what lab tests are you going to order to help work up this patient's anemia? LFTs, hemolysis labs. What's cluing you in that maybe you need to think about hemolysis on this patient's presentation? Yeah, so some scleral icterus, perfect. And then let's be specific. What hemolysis labs do you want? So you said LFTs.
If you really like to say it's here.
Okay, we want hapto, LDH.
Here,
Smear, what are you looking for in your smear?
just size, fragmented RBCs, maybe you have an element of like iron deficiency, anemia, some hypochondroplasia, so.
Great. Table 3, anything to add in terms of other lab tests you'd want to order?
We probably would get it out of PS13.
Okay.
Seems somewhat consistent with potential TTP.
Okay, great. And then what is cluing you in about possible TTP or a thrombotic angiopathy?
Well, she's definitely having focal neurologic deficits, right? Like she has weakness in her right arm, she has dysarthria, and then, she has this thrombocytopenia association with her anemia. So thinking about like, we don't know if she has multi-vessel status, that would be one thing, and then for creatinine is 1.5, but on our baseline, which is like renal failure, don't have vitals, or you said her vitals, not febrile, but definitely has some signs of.
Great. So let's say that you guys got the smear. There are schistocytes. Her haptoglobin is less than 30, undetectable. Her LDH is 1,000. Her total bilirubin is 3, and her direct is 0.5. The Adams 13 takes about a week to come back, so you're not going to get that for now. So we have a possible working differential. So Dante's team was worried about maybe like a TTP. Take about 30 seconds with your team. Talk about what you're going to do to manage this patient while you're still working up her anemia.
Yeah.
All right, so let's come back and manage this patient. I heard some great conversations here at table 1. What do you guys want to do to manage this patient acutely?
Yeah, I'd like to give her some blood, so transfusion.
Okay, you're gonna transfuse her. What else are you gonna do?
We were talking about getting some imaging.
Okay, imaging. Okay, table 2. Anything different that you guys would do? Okay, so Dr. Beller saying steroids, plasmapheresis. Table 3, anything different?
Yeah, like flex, probably put in a line, call hemo.
Yeah.
Have a look at this. And then, I don't know if you use steroid or IVIG for, like in the interim for, if that is a concern.
Yeah, so if you're really worried about TTP, the thing that you have to do is, alert your consultants because it can be a very morbid illness. So calling Hem-Onc, getting this patient to the unit to get Plex or Pherese is the right answer to do. They will sometimes give steroids. They can also give other things like rituximab if it's refractory. But great, so you are going to do plasma exchange until you get back your Adams 13 and you're calling Heme to say, hey, I'm concerned about this possible diagnosis.
Is there any, when this set in, when she started getting weak and dysarthric?
Do we know what?
When it started?
Just before she came to the hospital.
Like
30
in the
minutes.
last hour or two?
Yeah. TTP can cause thrombotic events, which is why this patient is having these symptoms.
Not if, we not transfuse myself. Yeah.
So I would talk to Heme because it's going to depend on how fast you can get plasma exchange running and how symptomatic she is. So if her vitals are normal, then she probably had this for a little while. She can wait. She will need blood eventually, but the main thing is to deal with her antibody that is there. All right, last one in this session. We have a 75-year-old male. He's admitted for CAP. There's been no change in his clinical course from admission to hospital day 1. His CBC on hospital day 1 had a hemoglobin of 15, or on admission rather, and then hospital day 1, he dropped down to 7. His vital signs are completely normal. He says he feels great. You go talk to him, and there's no altered mental status, no bleeding anywhere. You listen to his lungs. He's got a little bit of a consolidation in his left lower lobe, consistent with his pneumonia that he's admitted for. He has his antibiotics running while you go examine him. And so take about 30 seconds with your teams and give me the thing that you're going to do to work up this guy's anemia. No heparin. He's just on antibiotics for his CAP.
Yeah, I think that's a good place to start.
It's an
All right, I am hearing some great answers by table 3 down here. So let's come back together. Table 3, what are you going to do to work up this guy's anemia?
Oh, so recheck it.
Yeah, what makes you want to recheck it?
Say it.
What's prompting you to recheck the CBC as opposed to, calling the blood bank and getting that massive transfusion protocol ordered?
It does not seem consistent with his overall clinical presentation.
Perfect. And what would you expect to be different if you truly had lost blood?
Altered medication, vital signs, stuff like that.
Yeah, so his vitals and his clinical status are not consistent with him having lost half of his body's blood. So you could recheck his CBC. Anybody else have anything different they would do?
Question.
Sure.
Kind of related. So we were thinking, if this was a true CBC, thinking about like a bone marrow suppression type picture, how quickly do you see that evolve in somebody who's like, whether it's infectious or new medication, developing a pancreatitis?
Yeah, so it wouldn't happen in the course of hours. So that would be more days for a medication-induced bone marrow suppression. Great question. Okay, so we went through these 3 cases, and my hope is that you all now realize that there are only certain things that can cause a hyperacute anemia. So hyperacute meaning hours to days. There are only 3 things. It's going to be bleeding, hemolysis, or some sort of lab or logistical error. So like they draw up a line that is also infusing the patient's bolus or their antibiotics. The branch point that I use when I'm thinking about the 3 of these is their clinical status. So you do your physical exam. If you're seeing blood, you're seeing ecchymoses, they're now tachycardic and hypotensive. Obviously, you're thinking about bleeding as the cause for their anemia. For hemolysis, just like you guys picked up, if they start having some scleral icterus, their bilirubin is elevated and it's mostly indirect. If they're having thrombotic events or a clinical presentation consistent with a MAHA or a TMA, then you're thinking about hemolysis as your cause. And then for lab error, just really looking at your situation, like Ben pointed out perfectly, that if a patient has lost half of their body's blood, you would expect their vital signs or their clinical exam to have some sort of reflection of that. And so if there is nothing to argue towards a clinical change, just redraw the CBC and check it and see if it is true anemia. When we're looking at hemolysis, the number 1 question that I ask myself is, are there schistocytes present? And if it's a yes, then you have to think about your MAHAs and TMAs, because those all require urgent action. It's not something you're going to sit on and think about and wax poetically in your note. Like, you need to start calling people and making sure you're dealing with the underlying cause if that's what this patient has. If there aren't schistocytes, it's more of a chronic thing. You can think about getting a Coombs test. to differentiate between an autoimmune hemolytic anemia versus some other cause. And so lots of things can cause a hemolytic anemia that's not autoimmune. There are drugs. Anybody have any that they think of commonly? Antimalarials, anything else? Sulfa, I'm hearing. There's a type of medication that has sulfa in it that is notorious for doing this. So sulfonylureas can actually cause hemolysis. And then what's another really common one? You have a patient going out on a high dose of steroids. You put them on something for prophylaxis. Or dapsone, right? We check G6PD to make sure that they're not going to hemolyze if they take it. There can be mechanical sources of hemolysis. So if somebody has a mechanical valve in their heart, they might hemolyze just from the sheer forces in their blood. And then various infections can also cause a hemolytic anemia. So like Clostridium can sometimes cause it, or like Babesia is also known to do that. So obviously you have to correlate these with your clinical picture. Who here has had a patient who's had an acute blood drop overnight and has suggested checking iron studies the next day to work them up?
Or a B12.
Or a B12? Yeah, so Kyle's the only brave one to raise his hand, but as you guys can see, nowhere in this algorithm am I talking about checking B12, folate, iron studies in a patient who has a hyperacute anemia. So please remember that for next time, like if your patient overnight has dropped, like do not suggest checking iron studies. You need to be thinking about like, are they bleeding? Are they hemolyzing? Was it a lab error? Questions about this part of our algorithm? Okay. So we talked about hyperacute anemias. What do you guys want to do next? Acute or chronic?
Acute.
Great. So we'll jump into our next section. So we have a 68-year-old female. She's seen by her PCP for fatigue, petechia, some gingival bleeding. She's lost 10 pounds and she's got some night sweats. She has a CBC that was in the chart from 6 months prior. And then on the right, we have her CBC today. So once again, talk with your teams. What are you going to do to work up this anemia? And what are you thinking about in terms of a leading diagnosis? All right, let's start with table 1. What do you guys want to order to work up this patient's anemia?
CBC with a differential, a smear, and then and the consult each month. And yeah, I'm sure that was a lot on there, but
Great. Table 2, anything different? No. Table 3, check anything else? Okay, wasn't trying to fool you guys. Yes, this patient has symptoms that are concerning for a possible hematologic malignancy. So Michelle, our QI chief, will tell you not to get the differential if you don't need it because it's expensive. As a future hemonc person, I always get the differential because I'm interested to see what things look like. But on your differential, you'll sometimes see if they have blasts that are circulating. And again, on your smear, you can actually look and see if you go down to the lab. To see if there are blasts that you can visualize. And then Anya is correct. The ultimate way to diagnose this patient is to consult team, get a bone marrow biopsy, see what it shows. The things that should clue you in on this patient's CBC is that not only does she have a new anemia and clinically her symptoms are all consistent with the possible malignancy, but her other cell lines are also affected. So you're worried about something that's more inherent in the actual bone marrow itself, and it's more of a production issue. Questions on that case? Okay, let's go to our next one. So we have a 30-year-old female. She has a history of lupus. She is coming in with dyspnea and jaundice. She has a CBC in the chart from 3 weeks prior. Her hemoglobin was 14.1. Today it's down to 10. For her physical exam, she's borderline tachycardic. She's got her malar rash, and she's got some scleral icterus. So again, you guys know the theme now. We're going to talk about each case with our teams, chat about what you're going to order, then we'll walk through her labs.
Yeah.
All right. So let's go with table 2. What studies are you guys going to order to work up this patient's anemia? Great. So we're going to do our same hemolysis workup because she has some scleral icterus. We're worried about that. And so what if I told you that her total bilirubin is 3.1, her direct will be 0.9, her LDH is 500, her haptoglobin is undetectable. Table 3, what are you going to order next? Great. A Coombs test. Do you guys know how the Coombs test is done?
Take the serum. They take serum and then throw in the Coombs reagent that is positive and it's the antibodies within the serum.
Great. Excellent. I will drop in a representation for you guys. Ben described it perfectly. So when they're doing a Coombs test, what they do is they take the patient's blood. If they have an antibody against their red blood cells, which is visualized in blue, it might be present in the serum and attached to the blood. They then mix it with an anti-human globulin that I've marked in green. These are usually anti-IgE or C3d antibodies. And then if it's positive, so if the patient has an antibody directed against the red blood cells, it will agglutinate or coagulate in the tube. And so that would be considered a positive test. If it didn't coagulate, it would be a negative test. And so it tells you if they have some sort of autoimmune antibody working in their serum. Questions on the Coombs test or the DAT? Okay, so we're going to order a DAT on this patient. And it comes back positive 3+ for CD3 and IgG. So what does this patient have? Not quite. Yeah, do you know what type or what the different kinds are? Yeah, warm and cold. Brittany, did I hear you say something? Yeah. So Brittany is saying it's a warm autoimmune hemolytic anemia. And you'll know that because these antibodies are positive. Usually in cold agglutinin disease, they have different antibodies that are positive. It's an IgM mediated process. And so that would be what comes up when you get back your Coombs test from the lab. Great. And so when I think about sort of acute anemia, so things that are happening in days to weeks. The way that I think about it is either you can't make it, so your bone marrow isn't working to produce blood cells that are normal. You're destroying it in more of a chronic process than compared to the acute things that we discussed, or you're losing it again. So you have a slower bleed than something that's going to put you into hemorrhagic shock. For people who can't make, I think about, do they have a primary blood cancer? And so things that will clue you into that is, are other cell lines affected? What's their clinical history? Are they losing weight? They have fatigue, they have lymphadenopathy, or evidence of DIC. I also think about viral exposures. So what's the classic virus that can cause a temporary aplastic anemia in people? Yeah, parvo. So you have your person who's a daycare worker, they were sick with the viral illness, they come in with a rash and low blood counts. And then I also think about new meds. So Kira, you had asked, like, what's the timeline for this? There are tons of medications we can give patients that will cause direct bone marrow suppression. One that we don't often think of, but can happen, is linezolid, which is why if you ever get a transfer from BMT, you're like, why are they always on Vanco instead of linezolid? It's because they're already suppressed in terms of their bone marrow function. So they're usually on Vanc instead of linezolid, which can cause further suppression. For the hemolysis, we've already talked about the workup for that. Your first question is schistocytes, yes or no, and then you go down your autoimmune pathway. And then for bleeding, obviously we know it's a clinical story and your exam that will tell you if they're bleeding. Questions on acute anemia workup? Okay, so we have done hyperacute, we've done acute. The last thing that we have is chronic. And so we have 3 cases. I'd actually like to start with the middle case. So we have a 19-year-old female. She is coming to you in your PCP office to establish care. She has a family history of low blood counts. She also has heavy menstrual cycles. Her physical exam is totally normal for a 19-year-old. You check her CBC, it comes back with a hemoglobin of 10. And so chat about what value you're going to look at next to help guide your workup for this patient's anemia. Starting with the middle one. All right, so let's do table 3. What number are you going to look at, or what lab are you going to check for this patient's anemia? Iron studies. Okay. Table 2, anything different that you would look at first? No? Table 3? Yeah, so we're going to start with our MCV. So what if I told you her MCV is 65? So what lab values are you guys going to check next to work up her anemia with an MCV of 65? Okay, so now we're really pushing for a ferritin. And what if I tell you her ferritin is 75? It's normal. Yeah, so then if we've ruled out an iron deficiency anemia, she's not iron deficient, her ferritin is normal, but she's still anemic with a low MCV, so microcytic. We're thinking about things that are inherent to the cells themselves. Great, we will come back to her in just a second. Let's look at the first guy. So he's a 59-year-old male. He's coming to clinic for hemorrhoid follow-up. He saw somebody in clinic 3 months ago. He had some hemorrhoids, some rectal bleeding. He says now he's having a change in his stool size. His hemoglobin has gone from 12.8 to 11. He's got some conjunctival pallor. He's got some tenderness in his right lower quadrant. This is not meant to be a trick. What do you guys want to check next? Great, so we're seeing a pattern here. We're checking the MCV. I'm gonna tell you that it is 70. Now you're gonna check. Iron studies, do you want all the iron studies or is there one in particular that's gonna help you the most? Yeah, great. So the ferritin is gonna be what clues us in about iron deficiency anemia. His ferritin is less than 5.
Yeah, FOBT is probably a colonoscopy.
Yeah, great. So Kyle's like, why are we playing around? Let's just get to the final diagnosis. Yeah, so you send this guy off for a colonoscopy. Comes back, he has, colorectal mass. So he has iron deficiency anemia due to his cancer. All right, and then last we have our 32-year-old male. He's admitted for alcohol withdrawal. He has no history of cirrhosis. He's here at the VA, getting his SOS protocol. His hemoglobin is 10. MTV. His MTV is 106. What do you want to do next?
We'll check B12, we're not supposed to check folate.
Great, so now we're thinking about checking B12 and folate. Anybody else have anything different they would do?
Oh, well, alcoholics will have a high increase in B12.
Yeah,
So do I need to check B12?
great question. Seniors, would you check a B12 and folate in this patient who's admitted for alcohol withdrawal with a macrocytic anemia?
Probably difficult, or probably.
Okay, so just empirically give B12 and folate.
I think you can check B12.
Okay, great. Well, let's say this person just got empiric therapy, but our next one, you have a 31-year-old chief medical resident who's been here at the VA for an entire year, only eating their meals here. They're complaining of some fatigue, some neuropathy, a hemoglobin of 9.9. I'll give you the MCV, I'll spare you. It's 110. So now what are you guys gonna check? Okay, so we're gonna check a B12 level. Let's say that it comes back at around 201, which is just 1 point above normal. Now what are we gonna check? Okay, methylmalonic acid. What is its partner in crime? Yes, homocysteine. And then what if I tell you that her MMA level, we don't know who this person is, we're all guessing here, is 5. Homocysteine level is 30. I'll tell you these are both high. What diagnosis do you want to give this person?
So if they're both high, then it's technically folate deficiency.
It's the other way around. So if they're both high, it's B12.
Okay.
Yep. So then folate, they would have a normal MMA, but just an elevated homocysteine. Okay. So for this side of our algorithm, we were looking at chronic anemias. And so these are things that have been happening for months in patients. When I think about chronic anemia, I really do use the MCV to guide my workup. So MCV is a measure of the volume of the red blood cells. And so our normal value is between 80 and 100. High is anything greater than 100 and low is anything less than 80. And so, that second patient that we had, if you guys remember, the 19-year-old, her ferritin was normal, but she was anemic. I actually look at the red blood cell count as my first step when I have somebody with a microcytic anemia, because if their red blood cell count is normal or high, that means they can produce cells. They're just cells that are kind of small. And that clues me in. They probably have a thalassemia or some sort of inborn error of their RBCs being formed. If their RBC count is low, meaning that they're not producing many blood cells and they're small, then I check a ferritin. I don't bother with the rest of the iron studies right up front, because the ferritin will tell me if it's low, then they have to have iron deficiency anemia. That's it. If it's normal or high, then that could be your patient with anemia of chronic disease. Questions on this part?
Yeah, if we end up in the anemia of chronic disease category with a 19-year-old.
So you'd have to look for other conditions that would cause for anemia of chronic disease for a super young person. So it would just be working her up. But, oftentimes you're like 70-year-old guys who have CKD and like heart failure and all these things. They come in, they're anemic, but then their ferritin's normal. They likely have anemia of chronic disease. for a normocytic anemia, so they're between 80 and 100, almost anything can cause it. There's really no one pathway I can give you to guide your workup. But the things that I will encourage you to think about for patients who fall into this category of anemia with an MCV that's normocytic is making sure that you think about things like an SPEP and a UPEP. Multiple myeloma is classic for presenting with a normocytic anemia. And so make sure you're asking them those questions, looking at their calcium level, checking out their creatinine. And then lastly, for people who come in with a macrocytic anemia, so an MCV greater than 100, the way that I sort of think about this is first by looking at all their cell lines. So if they have other cell lines that are severely deranged, so somebody comes in with an MCV of 110, they have very low platelets, their white blood cell count is also down. Then I think about like a myelodysplastic syndrome, send them off to hematology to get worked up. If their other cell lines are fairly normal or have been normal in the recent past, I'd first ask, is there significant alcohol use? If it's yes, I sort of just stop there and presume it's due to their alcohol use. If the patient's like, nope, I don't have any problems with alcohol, I don't drink, then I think about nutritional deficiencies. And so lots of times in our vets, if they're homeless or, all these guys who've like had wives that cook for them and then they pass away and they're like living by themselves and can't cook to save their lives, ask them about nutritional status, see how they're doing with their PO intake. And if you think that's a cause of their deficiency, you can consider checking a B12 and folate. If it's low, then you have your diagnosis for either one of those. If it's normal, but you're really convinced because it's low normal, or you think this person has terrible nutrition, you can check a methylmalonic acid and a homocysteine. If they're both elevated, then you have vitamin B12 deficiency. If your MMA is normal and your homocysteine is elevated, then you have folate deficiency. Questions on this part of our algorithm? Okay.
I have a couple
Yeah, you want to
things
ask some points about this?
for the crowd. So when we're talking about B12 deficiency from a pure dietary deficiency, meaning you're not getting enough that's even entering your body. Just on a broad level, where's B12 found in the diet? On a broad level.
Meat.
Animal products, including eggs. Animal products, including eggs. Okay, it's in some like non-animal products, but it's mainly in animal products, including eggs. So someone who's really at risk for B12 deficiency because it's not even entering their body are strict vegans, and in our like vet population, like someone who's on a tea and toast diet because they're just like eating bread and crackers and whatever. But everyone else, if it's from a pure dietary deficiency, they're usually going to get it in most forms of the standard American diet, also known as the SAD. But then with B12 deficiency, you can also have autoimmune gastritis or pernicious anemia, basically leading to malabsorption of B12. So B12 is really definitely. As far as folate deficiency, there are articles swirling about in the universe that suggest that checking a folate level is a low yield, kind of wasteful test. Does anyone know why that might be? Why would it be a waste of time to check a folate level?
Because tea and toast is supplemented with folate. Everything is
Okay.
supplemented.
Where does folate exist in our diet? Whole grains, fruits, vegetables, meats, cereal. It is pervasive in our diet. So in someone who has folate deficiency, or someone who doesn't have folate deficiency, would you want them to eat food? Would you suggest that someone without folate deficiency eats food?
Yeah.
Yes. Someone with folate deficiency, would you suggest that they eat food? Yeah. So the treatment for folate deficiency is eating food if they're not getting enough in. Now, there's some clinical situations, someone's on methotrexate, someone's taking a prenatal vitamin, and they suggest like higher levels of supplementing folate. But even in this alcoholic patient, you'll typically see us give folic acid, but the treatment for his folate deficiency is basically going to be eating food.
Yeah, it's things we do for no reason. You just treat the patient. You don't have to check the test. But for completeness, I included it on our flow sheet.
If it's a pure diagnostic mystery, sometimes for academic purposes, you can nail it down with the level. But like generally speaking, your alcohol withdrawal patient you suspect it, just tell them to eat food.
Okay. So this flow sheet, I will email out to you guys in our summary, and I'll leave the cases on there so you guys can think through them. But my hope is that this provides you at least a basic framework for how to think about anemia in your patients. So, if you look up anything on UpToDate, it's always like, what's the MCV? But that's not a very helpful thing when you have a patient with a hyperacute anemia. So it's happened in days or hours. Again, only 3 things can cause that. They're bleeding, they're hemolyzing, or it's an error. And so don't waste your time checking iron studies and a TSH and a B12 level in a patient who has an acute change. For these acute processes that take days to weeks, your history is going to be the thing that really nails it down. And then you can order your diagnostic testing based on that. And then for chronic anemias, I do use the MCV and go off of that. Remember that we can check different things like the red blood cell count to figure out if it's a thalassemia issue versus an iron deficiency issue. And then obviously for your macrocytic anemias, you're making sure there's no other major bone marrow process going on. And then asking them about their alcohol use, their diet, different things according to that. So TSH is another big one that can cause it, HIV. So you're investigating those causes. Obviously, it's impossible to cover every single cause of anemia in like one organized table or algorithm. So I tried to keep it basic for you all. But does anybody have a patient that has an anemia that you could walk through this particular algorithm with? And you feel like it could help you come up with the answer? I guarantee that at least 80% of the patients who are here are anemic. Who here has checked iron studies in this last week? Raise your hand. Okay, great. Mike, do you want to talk to us about any patients on your team and what maybe their general values were?
I just know that we ordered them.
Okay. We'll definitely take this back with you to your workrooms and see if you can figure out using this algorithm what kind of anemia your patient has. Yesterday, our nutritionist came and talked. I put up the little guide that she made in each of the rooms. So in the team D and X workroom, it's taped up on 4 different stations. Erica, it's behind you where you sit. For Julia's team, it's behind, or it's above where she sits. And then for team A, it's above Catherine's desk. So please feel free to reference that. And if you have questions about nutritional stuff and how to order it, her contact info is also on it. Any questions at all from today's conference? Okay. Tomorrow, Dr. Borg is coming to give a AKI in the ICU lecture. Friday, we will have a GI case conference. And then that'll be it for your 3rd week of BA awards. Come chat with me if you have any questions, comments, concerns. Thank you all.
Thank you.